Greetings from Austin, Texas. My name is Dr. Steve Berkowitz, and I'd like to spend a couple of minutes with you discussing and sharing what I think is one of the most difficult decisions that a chief medical officer has to make. And that is, how do you balance your clinical time and your administrative time? Being a CMO is a specialty in and of itself. The scope of practice is different. The skills requirement are different. And the fact of the matter is, simply being a good clinician does not necessarily mean you're going to be an effective chief medical officer, because it is such a different specialty. It probably takes at least 3 to 5 years, or maybe more, to really feel comfortable in your role. So that's why this whole idea of transitioning from a clinician to an administrator full-time is a very, very difficult decision for each one of us to make. When I look around the country and I look at what are the characteristics of the top CMOs, 3 things come to mind. First is the ability to balance both clinical skills and business skills and feel comfortable dealing with both of them. The second is for the CMO to see himself or herself as not just a representative of the medical staff, but rather have the interest of the entire population health, the entire system, and be an advocate for what is best to promote the health of all the communities that that system is involved with. And thirdly, and maybe most importantly, that the CMO maintain a love for clinical medicine. Now, why would a physician want to continue clinical medicine in the first place? Well, there's really 3 reasons. First of all, we like it. We're good at it. It's what we've done all these years. It kind of is what brought us to the table. We enjoy clinical medicine and therefore are reluctant to give it up. Secondly, it's our comfort zone. We're used to it. We like it. Sometimes administrative or political decisions can be very, very difficult, and we can take at least some solace or comfort in going back to the clinical side of medicine. Thirdly, many physicians feel that continuing to practice clinical medicine is a good way to maintain the credibility with the other physicians and administrators. Well, I kind of want to dispute that one right off the bat. I really don't think that that is really a major issue. In fact, once you make the initial step to being a chief medical officer, I think that's where the credibility piece can manifest itself. And I think seeing additional patients is relatively minor. But in either way, what are some guidelines that I can offer to CMOs? First of all, I used to say that if a hospital has 300 or more beds, it justifies a full-time FTE, chief medical officer. Well, those are before the days of many of the things that have been expanding our roles, such as the regulations and the core measures and the pay for performance and the physician groups, etc. The role of the chief medical officer is clearly expanding. And therefore, I think smaller hospitals really should benefit from a full-time chief medical officer. And you can't just simply say it's the number of beds. A lot of times in transition, you may make the position, for example, 50-50. And that seems to work, and everybody's happy for a while. But what I've found in working with many, many CMOs is that 50-50 can very rapidly become 60-60 or 70-70. And many, many times that CMO feels that he or she is doing at best a mediocre job in all of them. And it's a very unsettling and uncomfortable feeling. Because ultimately, the position evolves, in my book, into a full-time experience. Now, when I look back at myself, how do you best manage this? I believe you can stay well involved in clinical medicine without the need to actually practice clinical medicine. Now, for some specialties, the transition is a little intrinsically easier. For example, ER docs can change the number of shifts per month, or hospitalists can decrease their number of shifts. For those of us in primary care, or even surgery, or most of the other fields, this becomes more and more difficult once you reach the 50-50 plateau. And as you start to do less, one way of looking at it is, would a patient want you as their doctor if you're only in the office 2 to 3 days a week? So I think the trick is to really stay involved. I do so by being on several boards, and I work in all sorts of different areas clinically that do not require the actual practice of clinical medicine. I think it's also important that we have an understanding of the true scope of our job, and that it gets bigger and bigger, and it's a specialty in and of itself, and it's going to require all of the attention or more than we ever gave to our individual practices. And finally, if you want to maintain your credibility, do it through honesty, integrity, and making the right decisions for the health of your community. Simply practicing medicine as a way to maintain your credibility, I think, is a wrong assumption. So when I look back at my own career, I think I made the right decision for myself, for my organization, for my community, and most importantly, for my patients. I feel as a chief medical officer, I've been able to do a lot of good for a lot of patients, and I've been able to practice medicine on a macro scale without actually practicing medicine. So I wish you all the best. I think it's a wonderful career. I hope you do well through this transition because it is difficult. But ultimately, it can be done, and the right decision that will be made for you and your position. So thanks for listening to me. I look forward to talking to you at any time. Have a great day.